Okay, so we are going to go through our health history form, and I'm going to go through and explain what you should be looking at, because every morning or afternoon even, all patients, when you bring them in, the thing that we're looking at, it's going to be the same thing every single time. We're going to look at their health history. We're going to see like if there's anything that we should be concerned about, a cardiac issue, a breathing issue, allergies, medication. And then we're also going to be checking the x-ray every time. If it's surgery, we need to make sure that that x-ray is no older than a year. For a consultation, it needs to be within the last 6 months. And then we are going to make sure our room is set up the way it's supposed to be in coordination with possibly that health history. If we need to take an x-ray, we're going to make sure that we take one. And yeah, that's kind of like our process every time. You should never be bringing back a patient and you haven't looked at their health history. So I don't have it printed out to be able to show you. So if you can print it out at the office or just be playing this video at the office where you can scroll through. So our first page is the welcome to practice page. This really isn't a concern for you. You can pretty much scroll right past it. It's just gonna be the patient's basic information, who their doctor is, who their pharmacy is. This is a good spot like if you needed to find somebody's pharmacy, but they don't always fill it in. So sometimes you look and it's not there anyways. But this is gonna have like their referring doctor. If they have an orthodontist, that might possibly be on here. And it's gonna have their insurance information possibly. But like I said, for the back, this is kind of a page that we just scroll right on by. So our next page is where it actually starts the health history. So the first line, it says reason for today's visit. Again, I mean, if they fill that in, but that's kind of also in their own words. So really, to find out why they're here, the reason that you really, or the way you really want to be finding that information is to be looking at their referral. So when you look at their health history, when you look at their x-ray, we're, for a consultation specific, more so, we're really looking at that referral, and we're going to see that the treatment that we're going to give is going to match up with that referral. Let's say our patient comes in and it's for all 4 wisdom teeth. Their referral should say all 4 wisdom teeth. If we aren't going to do all 4, we will send a letter to the general dentist and we explain what our treatment's going to be. So we need to go based off our referral, because really the general dentist is sending that patient to us and saying, this is what I want done, because they're the one who's going to continue their care. So we don't usually like to deviate from that too much. If we do, we really need to have a justification and a discussion with that patient that really shows like why we're going to do it this way. So that's what our referral is good for. And we also just don't want a patient coming in and saying, oh, I want to, have these 2 teeth taken out. And then the general dentist be like, what are you talking about? Like, those 2 teeth don't need to come out. So everything that we do really follows their plan, especially when it comes to things like orthodontics. You can go to 2 different orthodontists and they might come up with 2 different treatment plans. So let's say one orthodontist says, okay, to put them in braces and to give them a nice straight smile, we're gonna remove these 2 teeth in the front. And then maybe another orthodontist to go through and treat his patient the way he wants to, he's gonna say, oh no, we're actually not extracting teeth. What we're gonna do is we're gonna put an expander in the roof of the mouth and expand their palate so that way those 2 teeth have room. So everyone's treatment plan is really gonna be specific to their general dentist, so we need to make sure we're following that. So then it's gonna have their height and weight. Not really a concern. Once we see them, that's more so what we are concerned with visually, because you could weigh a certain amount or be a certain height, but when you see somebody and you see like they have a really bulky neck, or they maybe have like kind of that fat hump that we talk about, or maybe they are hunched over, or maybe they don't have full range of motion for their neck to be able to move because of an injury. So a lot of what we do is going to be just kind of seeing our patient and seeing how they're sitting in the chair and what they're capable of doing. Because if somebody has that big fat hump in the back, sorry, you might be able to hear my dog's nails clicking on the floor. So if they have that big fat hump, go lay down. If they have that big fat hump on the back, if we have an emergency and we need to intubate them, you have to turn somebody's head all the way back and kind of like sit them on the base of their head. If they have, like maybe if they're kind of like hunchback and they don't have the capability of doing that, or if they have a neck injury, or if there's that little like hump, then that could change what our treatment's going to be based off safety. You also may have like a woman who has a very large chest, and all that weight is going to be sitting on her when she is sedated. So then that could be something that might be a concern. There is, I forget what it's called, there is some sort of ratio where when somebody is laying flat, where their head is versus where their chest is, that can be an indication of like a difficulty in a sedation and surgery. So next line, have there been any changes in your general health in the past year? Okay, I'm not paying particular attention to that. If there is, it's going to be listed in their health history, so skip that. Are you under the care of a physician? Truthfully, don't care. If there's something major going on, it's going to be listed in their health history, and most people usually are being treated by a physician for something. And then, have you had any illnesses, operation, or been hospitalized in the last 5 years? If somebody, I don't particularly like this question because 5 years is something so broad. Something could have happened 5 years ago and now you're in a completely different health state. So I don't particularly pay too much attention to that because again, 5 years is so dramatically long. If it was like a year or two, then I would definitely pay attention, but I kind of do skip by that one. Do you have any unhealed recurrent injuries or inflamed areas, growths, or sore spots in or around your mouth? This would be a concern to me if this patient was being seen for something like a biopsy, if they have a growth that continues to reappear, or a lot of inflamed area, because that could be, go hand in hand with what they're being treated for in terms of like, maybe they have an infection that just continues to reoccur, but it's also not particularly going to change our course of action. So I'm not paying too much attention to that either. This top part is informative, but when we get to the questions, I'll tell you what we're really paying attention to. So our next one, do you have a prosthetic joint or implant? This is a question we're really paying attention to because if somebody has had like a knee replacement or a shoulder replacement, these are patients that their doctor is going to tell them that they need to pre-medicate prior to a procedure. So that's going to be important for us because if I see that, I need to ask them, you have a prosthetic joint, did you pre-medicate today? Because if they didn't, then we may need to cancel surgery or we might need to pre-medicate them right now and then wait to start surgery in an hour. So that of these questions in the top of this paper, definitely line number 6, do you have a prosthetic joint, is very important. Do you have a heart valve replacement or vascular graft? That is important because anything that's going to have to do with our ABCs, airway, breathing, circulation, so heart and lungs is something that we're going to be paying attention to. So that for sure we're going to be looking at. Have you ever had general anesthesia or IV sedation? Particularly, I say I don't care about this line because unless they had a complication, which is the next line. So the next line is, have you or a family member ever had an unusual or serious reaction to general anesthesia or IV sedation? So with that line, the reason that's in there and the concern that we're curious about is going to be malignant hyperthermia. So malignant hyperthermia is an emergency that we can have in the office. Malignant hyperthermia, okay, go lay down. Down, sorry. My dog wants attention. So malignant hyperthermia is a complication that we can have in surgery, and that's going to be when essentially your body temperature drastically rises, and usually our brain kind of has this like off switch to maintain homeostasis, but there's a failure there, and the body temperature goodness drastically rises, and your CO2 output can triple. You start to have muscle rigidity, and if it's not treated, then this person can potentially die, or more so will die. So it needs treatment. So with sedation, we in our office don't give anything that's going to trigger that. So the triggers for malignant hyperthermia are going to be inhalation anesthesia, and I know succinylcholine is one. I don't know if it's all paralytics, like ricramonium is another one that they typically use in the hospital. So when I say inhalation anesthesia, I'm not talking about nitrous oxide. So nitrous is something that we do give in our office. Nitrous is not in the same category. So inhalation anesthesia is fluorine. So like isoflurane, sevoflurane, desoflurane. When you go to the hospital, they put a mask over you, or you can do it in an ambulatory center too, but they would put a mask over, you breathe that gas, and that gas sedates you. We don't have that. So that trigger automatically out the window. Succinylcholine, we are only going to give in emergency situations. So if we got to the point of giving succinylcholine, we're already going to be calling 911. So you certainly can give succinylcholine and continue treatment, but as an office standard, we err on the side of caution. So if we are giving succinylcholine, then we are going to take a step back, say this is not something that's worth continuing today. We will reevaluate, bring this patient back, because at that point, this treatment is not going how we've planned it, and we don't want to continue. So if we are giving succinylcholine, we're automatically calling 911. Right now, the day I'm making this video, we have two doctors, Dr. Maharaj and Dr. Pham, and they are very much on the same page with that. So let's say years from now, you guys are watching this video, you have another doctor, who knows? If that doctor decides, that it's safe to continue, then we would need to remind them like, hey, actually, can be a trigger for malignant hyperthermia, and we don't keep the treatment for malignant hyperthermia in the office because we don't have any triggers for it. And if we do, we've already activated 911. So if it is something that we are not going to stop treatment, then we need to have the treatment for malignant hyperthermia to keep going. Otherwise, we need to stop. So when it comes to malignant hyperthermia, realistically, the only other thing that triggers it is genetics. So from what I have learned, in our particular area, we do not have many, family history of this present. However, up north, I believe, kind of like Michigan and over, there's a lot of, family history. It's more prevalent there. So we particularly don't have it, but that's what that question is referring to. That have you or a family member ever had unusual or serious reactions? The reaction that we are asking about is malignant hyperthermia. We have had one or two patients come in previously and they did have a family history, and we wouldn't treat them. We sent them to the hospital. So if somebody marks that majority of the time what happens is you ask them and they say, oh yeah, my dad woke up really sick, or my mom took a while to wake up. And usually I say, or they say, oh yeah, I woke up really sick. So I say, okay, were you at the hospital? And they were like, yeah. I'm like, okay, the drugs that we are going to give, we're going to give them just a little bit differently. We give a lot less anesthesia. We also don't give, the inhalation anesthesia. And a lot of the time when you're having a procedure done at the hospital, you are just getting usually more of a heavier pain medication, like an opioid, which usually does trigger some nausea. So I just say, the drugs that we give are very short acting. We give a lot less of them. So we also give an anti-nausea medication. So realistically, you shouldn't have that issue. Whenever we have been told this in the past, it's not an issue. We will keep it in mind, obviously, but it's just not something we're expecting from this procedure today. The chance of it happening is fairly low considering all of the things that are in place, all those different drugs, the low amount of drugs, and the antiemetic medication. So, has a physician or previous dentist recommended that you take antibiotics prior to dental treatment? People will mark this when they currently have an infection and their dentist has them on an antibiotic. This is going to be vastly different than somebody pre-medicating because they have a prosthetic joint. So when I see this, I'm like, okay, why have they recommended you pre-medicate? And the majority of the time it's followed by, oh, because I was just having an infection. I'm like, oh, okay, no big deal. I'm not concerned about that. However, if it is because of a prosthetic joint, then that's where we're gonna start to ask some more questions. So then we get down to all of our check boxes that we're going to be paying attention to. So rheumatic fever, I'll give you my bone to pick with this health history form. Have you ever had, or do you currently have? So some of these things, it's definitely important to know if you have ever had it. Other things, it's more so important if we know that you currently have it. So rheumatic fever, is this something I'm presently worried about? No, not particularly. However, rheumatic fever can cause heart valve damage, specifically the mitral valve. So there is a spot right below that says damage to heart valves and mitral valve prolapse. So that would be more so why I would be concerned with rheumatic fever, or if you currently have it. But otherwise, not the biggest concern in this present moment. So like I said, damage to heart valves or mitral valve prolapse. So your mitral valve, you have, you have 4 valves in your heart. So the trick to remember them is you try before you bi. So you have your tricuspid and then you have your bicuspid or your mitral valve. So that mitral valve is going to be on the left side of the heart. And what happens is your valves, they open to let blood through and then they close. When you have damage to the valve in the heart, it opens, but then it kind of like backflows and lets blood flow back into a chamber that it's not supposed to be going into. Blood is supposed to only flow in one direction. So when you have that, you can have like a pooling of blood. This can be something that leads to blood clots. When you listen or auscultate to those heart sounds, you can hear, kind of just call it like a swishing sound. So that would be something that we would, just really want to pay attention to. When we're looking through this health history, the other thing to remember is that the doctor has already had a full consultation with this person. The doctor has already gone through this entire health history. Really the thing that we're doing when we're looking at this health history, you obviously want to be able to watch and understand the anatomy of the body and understand really what's going on and what these things mean. It's important to know what mitral valve prolapse is. It is important to know, what happens with kidney disease and liver disease. Those things are important, but there's nothing that's really too specific right now, because at this point when you're going through this health history, it's that you're about to bring them back into the room and perform surgery, and we just need to kind of get an idea in our head of, if an emergency starts to happen, what are some things that I need to know about this patient? Or if, let's say, they have asthma and I start to hear wheezing, I'm like, oh, okay, now I'm concerned because that's a wheeze and I know they have asthma. If you never look at your health history and, you know, you start to hear a wheeze, you might think something entirely different. You might just think, oh, okay, it's just a positional issue with how they're sitting. Where if you already have that insight into the fact that this person has asthma, hearing that sound really grabs your attention more. So at this point, we are not looking at this health history to diagnose or to treatment plan. The doctor has already done that. He's already treatment planned. He's already deemed what's going to be safe. We're looking at the health history to know if an emergency arises, what do I need to know about this patient to either act quicker or act safer for them in that moment. So heart murmur I'm not too concerned with, because heart murmur, again, it says, have you had or do you currently have? Sometimes parents will mark a heart murmur because when their child was younger, they had a heart murmur. You can grow out of heart murmur. So, or you can just live forever, with a heart murmur, and it doesn't cause an issue. So that one, I'm kind of gonna go next. High blood pressure. High blood pressure is going to be a concern because we want to make sure they're taking their medication if they do have high blood pressure. High blood pressure can lead to things like a stroke. It can lead to damage to other organs. So your body is designed to have this standard pressure really kind of pumping through our body, getting that blood to our organs. Having high blood pressure, your vessels in your body are taking on these forces that they're really not built to be taking on. They may adapt over time and get used to it, but it's not supposed to be that way. Your organs, you kind of have to think they're also getting this like pounding pressure from that high blood pressure, and that can result in damage. And they're just, again, not supposed to be taking on that force. So that's something that we want to be concerned with. Also, more so for stroke is really our biggest concern. So if they have high blood pressure, then that can certainly lead to a stroke. That's one of the leading causes of a stroke. So we really would want to make sure that if they have high blood pressure, that they're not coming in with high blood pressure today. We want to be checking their blood pressure and monitoring it during surgery. We may need to give them labetalol during surgery to keep that down. And like I said, just make sure that they are currently taking their medication for that. Low blood pressure, this is going to be a concern more so for me when you have these tiny little 16-year-old girls coming in who weigh about 100 pounds. They have low blood pressure because if they already have low blood pressure and before surgery, they're not eating, they're not drinking, so they may be a little bit dehydrated. If this is somebody who is constantly, remaining really hydrated, and now we have made them NPO we usually say after midnight. Realistically, it's no clear, lay down. Sorry, my dog's trying to get some love. So it's clear fluids, nothing 2 hours prior. As an office, we say nothing after midnight. It's really 8 hours, but when you say nothing after midnight, then people, tend to listen more. But let's say their surgery is at 10 o'clock, 11 o'clock, and they maybe, went to sleep, let's say at 8 p.m. Maybe they go to sleep early. And so now they may not have had anything to drink from 8 p.m. and now it's 11. And then we are going to give them some IV fluids and stuff. But really our bigger concern with this patient is that they already have low blood pressure. They females in general, they may be, prone to anemia. So they could be on their menstrual cycle, and then they've also had some bleeding during surgery, and then they haven't eaten or drinking. So when it comes to low blood pressure, the thing that we're really going to be concerned with is if this patient's going to faint. So we want to keep an eye on that. And usually what I will do is I will tell the parents, especially if they're on their menstrual cycle also, say, today when you get them home, just make sure that if they're going to be in a lying position and they need to stand up, that they go from a lying position to sitting, kind of get their bearings for a moment, and then slowly stand. We have had it happen before where a patient has gone home and they got up too quickly and they fell and they smashed their face off of the coffee table, and then they were back in our office later that day. So you'll sometimes notice Dr. Maharaj being like, make sure you're moving furniture out of the way, just give them a safe area. And realistically, they should have somebody with them all day long. This is still a surgery, so it may, in some people's eyes, be a minor surgery, but it is still surgery, so we need to be careful with them today, have somebody watching them. Or realistically, like, just be, kind of waiting on them hand and foot, like, hey, would you like a drink? Bringing them these things so that they aren't having to do them. So that would be my concern with low blood pressure. The next one is chest pain or angina. So this would be a concern because that's going to be our ABCs again. So airway, breathing, circulation. So this is going to be our circulation. You have chest pain when there is ischemia in the heart. So when that blood down. So when you have ischemia in the heart, you have a blockage where blood can't flow, and that's what's leading to that chest pain. So we are going to probably ask this patient questions like, do you take nitroglycerin? Nitroglycerin is a vasodilator, and that can alleviate chest pain. There's going to be two different kinds of angina. There's going to be stable and unstable. So our unstable is going to be more of a concern. Stable is going to be like things when this patient climbs a set of stairs, they get chest pain. If they're running and they get chest pain, that's stable. Unstable is when it's completely unpredicted. You're laying watching TV and then you get chest pain. That's starting to show a progression, and that is something that's more of a concern. Either way, we don't love it. We don't love any of these. But unstable is going to be more of a concern. So if they've had a heart attack, obviously that's going to be a concern because that, again, is a circulation issue where the heart is not getting the blood that it needs, and it's causing tissue death, and it's preventing blood flow to the rest of the body. And we want to know about that. We also want to know when it was, because that's going to change treatment as well. So a regular heartbeat, it is going to be a concern. So some people may mark this because they have AFib. You can live a normal life in AFib. Atrial fibrillation, the thing that's more so concerned with that, and when it comes to surgery, is if somebody's marking this because they have AFib, your heart kind of fibrillates, it kind of like quivers, and blood's not completely flowing the way it's designed to. It can create pooling of blood in the heart, which when you have blood pooling anywhere, can lead to clots. So if this patient is going to be prone to clots, then their doctor is going to have them on usually like a blood thinner, and we need to have them stop any blood thinners prior to surgery. Or if they're taking like an aspirin every day for this, then again, we may have them stop taking that aspirin because we want bleeding to stop after surgery. So that's something that we would be paying attention to, and really more so the reason of why. Also a regular heartbeat, if they have something like supraventricular tachycardia, some people do have those issues as well. So just in general, anything with the heart is something that we're going to be concerned with, but that's more so like my little tidbit on AFib. So cardiac pacemaker, you have a spot in your heart called your SA node. Your SA node is the pacemaker of your heart. This tells your heart how fast it should be beating. So if somebody's SA node is malfunctioning, then sometimes you can go to the hospital. They kind of get you back on track, and then you may never have an issue again. Other times they try that, it doesn't work, and now you have an artificial pacemaker. So we would want to know about this artificial pacemaker. It really is not going to change our treatment too much, but let's say we are in surgery and something happens and something's going on with their heart, a pacemaker can fail. So that's really more so why we would be concerned with knowing this. You can have it fail where it's not working at all. And then you can also have, my grandmother had this happen previously where her pacemaker was detecting an issue and there wasn't one. So it was kind of like shocking her, and she could feel it and she was awake. So really just we're aware of that in the event of these things where it either stops working or it thinks that the body is not working when the body is working. Heart surgery, we usually, I think they need to wait 6 months, especially like after having like a stent or something placed before they can do any treatment. If somebody has had surgery, even if it is beyond that 6-month window, then they may still be taking blood thinners, which again is going to be a concern for surgery because it's going to lead to bleeding. So we would be concerned with that. Pneumonia, bronchitis, chronic cough. So again, this is my little bone to pick where it's, have you ever had, do you currently have? If they've ever had pneumonia, bronchitis, chronic cough, again, unless it's happening right now, I don't particularly care, unless it's something that's led to a long-term issue like COPD or emphysema. Those would be issues. But otherwise, just the fact that you had bronchitis last year, not really a concern to me. Or if you have bronchitis right now, please don't come in and do surgery. We need everybody to be in good health within 1 month leading, 1 week leading up to surgery. The reason being is that if mucus just from being sick is still in the airway, let's say, or like the nose, if you can't breathe through your nose, that's going to be a issue because we use a nasal hood. So that's how you're gonna get oxygen, through that nasal hood. So if you can't do that, then that's gonna be a problem. So you need to be able to breathe through your nose. If you just as of today can breathe through your nose, that's fantastic, good for you. But for us, we still are going to be concerned because you may still have mucus built up in this like lower portion of your, well, still your upper respiratory tract, but we breathe through our vocal cords, which is your larynx, and that is also where you intubate. So when you're awake and something kind of tickles our throat, our reaction is to cough. We cough and we clear our airway. When you're sedated, your body doesn't have that. So we can run into an emergency called a laryngospasm. So your vocal cords start to quiver. They start to open and close. And since we breathe through our vocal cords, it does make kind of a funny sound. It's called a crowing sound. So when you start to hear that in surgery, you'll instantly know the sound. But if we aren't suctioning well enough, if a piece of tooth goes back there, or let's say we are doing all those things, we're suctioning well enough, but somebody's been sick and they have a mucus build up here and our body is recognizing that. And when they were awake, they were coughing, but now that they're sedated, their body has no way of clearing it. So those vocal cords begin to spasm. Our goal is that we stop that spasm. So you do that with positive pressure air. And it kind of is a way of like telling your body like, okay, here's air, like knock that off, calm down, like stop your vocal cord quivering. In the event that that doesn't work because you can't clear the blockage. If somebody is sick, they have a mucus buildup, it really just probably won't happen. You won't be able to clear that. The body's going to continue to have that same reaction. Ideally, we want that noise to stop. If it does stop, that's good. Or if it stops, it may be bad. It might be that the vocal cords were opening and closing and now they've completely shut. Well, since we breathe through our vocal cords, if they're shut, we're not passing any air. So that could be an emergency that they're not breathing. So that's when we would give succinylcholine. You relax those vocal cords because our vocal cords are a muscle. And then hopefully we give succinylcholine. Like I said, if we give succinylcholine, we are going to call 911. But the hope is that we give positive pressure and it stops the reaction. So that's going to be why we want somebody in good health leading up to their surgery, specifically in our office. And also, if they are newly well, so today may be their first day, in terms of their CBC, their blood count, their white blood cell count may still be elevated, which would indicate an infection. And if your body just did fight off an infection, we may now also be concerned with the fact that we're doing surgery and you may be more prone to an infection. So it's just all around like not the greatest package deal of this. So we are going to stay away from that completely. Asthma, again, if the patient has asthma, we're going to be making sure that they bring their inhaler. We usually ask how often they use their inhaler. Some people may mark asthma and they haven't had an asthma attack in 5 years, which is great. But maybe they use it every day, multiple times a day, or it's only exercise induced. So it's going to be important that we ask those questions of like what triggers it, how often do you use it. When somebody brings their inhaler into the office, the first thing we always need to do is check the expiration date. So we do ask them that they bring their own inhaler. But if they're bringing it and they never use it and it's expired, if we run into an emergency situation and we're using someone's expired inhaler, you can guarantee that if this is something that's going to be reviewed legally, then that's going to be an issue for us. So any medication you're ever going to be giving, you always want to make sure that it is that the correct medication, the correct dose, the correct patient, that it's not expired. So if it is, I just notify them, hey, you are going to be wanting to get a new inhaler because you don't want it to be expired, and then in the event that they're at home and they need to use it. So I let them know this is expired. We're not going to be able to use this today. I'll give this back to you. You need to make sure that you get a new one. We would never throw it away. We give it back because they don't have a new one yet. So let's say they go home and they need it and now we've thrown it away. It's better to be using something expired than to be using nothing at all. So what we have been told, which we don't keep expired drugs in the office, obviously, but a drug can maintain up to 80% efficacy and function up to 5 years after its expiration. You can research that, but that's what we were told at one of our AAOMS conferences. So yeah, just make sure they have it. We would never get rid of something until we have a med to replace it, but we would pull out our own inhaler and use it in that event. But like I said, if you start to hear wheezing in surgery and you know this patient has asthma, you can act quicker and you can act in the patient's best interest, opposed to if you walked in completely blind to this patient's health history and you don't know what's going on. Hay fever, sinus problems, again, not really something I'm concerned with. We'll be able to watch their breathing during surgery and really go from there. Snoring is a concern, because snoring is an obstruction. So in our surgery, when patients start snoring, because our patients are moderate to deeply sedated, so they should still be breathing on their own. So if someone starts to snore, if you grab their chin and just lift their chin up during surgery, it's going to pull their tongue, because your tongue is attached here, it's going to pull your tongue forward, and then it opens that airway. So whenever somebody, you start to hear them just not breathing as well, you just take their chin and lift their chin. So usually we'll use kind of this part of our finger and hook underneath of here and lift. You want to make sure that you're not underneath here too far, because if I'm pushing here, then it's really creating more of an issue. You're looking for this tip of the jawbone just to grab that and push that up. And then what you can also do, you'll see Maharaj do this sometimes. He grabs their tongue and pulls it forward. And then again, opens the airway. Lifting the chin does the same thing, but the tongue is just a little bit more, direct. So snoring also is going to be something that's concerning to us because this patient may have sleep apnea, which is our next one, sleep apnea, and if they use a CPAP machine. So depending on the severity of their sleep apnea, this may be a patient who we have to continue to arouse during surgery. So these are going to be people that you're tapping on the shoulder. Take a deep breath for me, breathe through your nose, take a deep breath. So you really have to monitor these people and almost tell them to breathe. You have to really stimulate them. These people at home, if they're using a CPAP machine, which unfortunately a lot of people who have sleep apnea, they should be using a CPAP machine and they're not, or like a BiPAP or something. But a lot of people, they don't have a sleep study done. Maybe they don't have the insurance for it. So instead, these are going to be those people who are at home and they stop breathing for periods of time, and then, you know, they start going and they're gasping for air because they just don't have it. So you can certainly do that in the office where you just wait for them to breathe on their own, but again, they're going to wake up gasping for air. So that's why we're stimulate them the entire time. You know, take deep breaths, take deep breaths. And these are people who, in the event that they're so anxious that they need IV sedation, these are going to be those people who we really are keeping very lightly sedated. And they're going to be aware of this. This is a conversation we're going to have with them prior and letting them know, like, hey, you may remember more of this surgery than intended, you know, or not intended. We know that's the intention. But they don't probably want to remember it. Most people want to go into surgery, be completely sedated, and then they wake up, you know, when they're going home and they have no idea what happened in between. But this is a conversation we're going to have with them saying, you know, due to this health history, due to that risk, in our office, we don't intubate. We choose really not to. So we don't intubate. We try to stay away from using oral airways and nasal airways. We'd rather them be completely breathing on their own. To us, that's just a safer line to ride. So we certainly have them and we'll use them in the event that we do, but our goal is to have the patient breathing on their own. So this is a conversation that we will have with them of, like, you know, we're going to use a lighter form of sedation. We give them a little bit of Versed so that they still don't remember, you know, the surgery in full detail. But we are more concerned with their safety than anything. So difficulty breathing or other lung troubles, this again, airway, breathing, circulation, that's going to be a concern. We want to pay attention to that. Tuberculosis, please don't come into our office with active tuberculosis. Really the thing that's going to be concerning for tuberculosis, obviously, is it's tuberculosis, and there can be a huge medication regimen. So we just need to know. Emphysema is going to be one of those difficulty of lung problems. So I believe emphysema is the one that we nickname pink puffer. So these people are going to, you'll kind of see them, they almost tripod over. So tripoding, I'm kind of way back, but you kind of like lean forward. These are these people who are like bracing themselves. They're kind of going forward. They're in their chair. They've got their legs on their knees and they're like, so that pink puffer, that usually will be on oxygen, supplemental oxygen. COPD, we nickname blue bloaters. So they have a chronic obstruction. COPD, they may be on oxygen, they may not. There's a fine line to ride with COPD patients where you don't want to give them too much oxygen to the point that they are then dependent on it. You really have to be careful with your oxygen levels and what you're really giving these COPD patients. So with emphysema, these patients are going, the alveoli that we are using to breathe, essentially, alveoli are where gas exchange happens. So when you have a patient with emphysema, they have damage to those alveoli, so they don't have the ability to, they may be breathing, but their body lacks the ability to do that gas exchange, which leads them oxygen deprived. So that's going to be obviously a concern when it comes to surgery. Do you smoke or vape? This is going to be a concern, obviously, for not only the surgery, but also for healing. So if somebody is smoking, they're automatically an ASA class 2, and they will be sucking. So after surgery, post-op, it's sucking, like smoking, spitting, drinking through straws, creates negative pressure in the mouth, which will dislodge the blood clots and lead to a dry socket. Smoking and tobacco specifically also leads to vasoconstriction, and the heat that it generates in the mouth can become an issue, but the vasoconstriction, you need blood flow to promote healing. So the vasoconstriction prohibits that blood flow, which can then lead to a delay in healing. Chewing tobacco, this is going to be a concern if this patient's coming in for especially a biopsy. So if they're not, even during that consultation though, still, we need to be inspecting their mouth and making sure we don't see anything, because God forbid, maybe their general dentist missed something and then they're coming to us for treatment and then we miss it, and this patient could potentially be developing cancer and nobody's catching it. So every time we see a patient, we need to be evaluating the areas inside their mouth and making sure that we don't see something. And unfortunately, tobacco is a contributing factor to that, as well as other like herbal remedies. So tobacco, hookah, vaping. We had a patient, I had never heard of this before, but betel nut, it's like a nut that I think it creates like a euphoric feeling. I'm not an expert on this by any means, but that can apparently also contribute to cancer as well. Alcohol intake. Alcohol is going to be a concern prior to surgery because of it creates. Hi, my dog's going crazy. So it can create an anesthesia issue where if you're drinking a day or two leading up to the surgery, your body's kind of already processing that toxin out of your body. And then when it comes to us giving anesthesia, your body's kind of already in that mode of over processing things out, and you just don't want to go to sleep as well. So these are patients who, if they do tell us they had a glass of wine the night before, once you do this for so long, you do see that when you start to sedate them, it almost has an opposite effect where, instead of becoming sedated, they become more arousable. So they start to talk more and they want to have a conversation with you. And a lot of the time, even if they tell us, oh, I don't smoke marijuana, when you see that reaction, you're like, okay, you probably do. But yeah, so definitely you will see this when they do say, oh, I do smoke marijuana, or I did drink a glass of wine last night. We then had that conversation of, this is what we're going to be expecting because of this. And you just are more aware. Let's see, blood transfusion. I don't particularly, it's not something that's going to change our treatment, but it may tell us that this patient lacks things like possibly they're anemic, and again, we could be concerned with fainting, or maybe they have low iron, or there's usually something, maybe an electrolyte or something that you are missing that is leading to this need for a transfusion. So really, it's not the transfusion itself that really is a concern for us, but more so what is leading to you needing that transfusion. Blood disorders such as anemia, again, we talked about fainting, bruising easily. Facial surgery in general just usually leads to bruising, but bruising easily, they'll usually mark this, especially when they're on a blood thinner. So if they do mark bruise easily, and maybe they are an older patient and I don't see any medication history, that may lead me to be like, are you taking anything? Bleeding tendency and abnormal bleeding, again, same thing. If they're marking this, but they're not putting any medication down, it's gonna send off some alarm bells in my head. Hepatitis, jaundice, or liver disease, we are going to, if it's hepatitis, in terms of if we're thinking about this as an infectious disease process, we are going to treat everybody standard precautions as if, everybody is treated the same. So whether you are completely in good health or you have hepatitis or you have HIV, every surgery is going to be treated the same. So I don't care about it as a infectious standpoint. We do care about it though in terms of your liver is going to be metabolizing these drugs. So if you don't have that ability, then that's going to be an issue. Liver disease can also cause a array of issues, especially with your blood. So this patient could be lacking platelets, which is a clotting factor. So that would be a concern. The other one is jaundice. So sometimes you'll see parents mark this because it says, have you ever had? And then they're like, they were jaundiced when they're a baby. And I'm like, well, they're 25 now. I think they're okay. So that may be marked for that. Infectious mononucleosis, otherwise termed the kissing disease. See my little puppy standing up back there. I don't care unless you currently have mono. Gallbladder trouble, again, not really a concern for us today. Fainting spells, again, we talked about that. That's going to be an issue. So before we move on to the second side of this health history, I'm going to stop this video here. I'm going to deem this part 1 of our health history, and then we will move on to question 40 of the health history, work from there, and then finish it out with the drugs and allergies.